Hi, I'm Srimati Manimanan. This is my final project for BMI224. My drug gene pair is Celecoxib and CYP2C9. A brief introduction to the drug. Celecoxib is a non-steroidal anti-inflammatory drug used in the treatment of osteoarthritis, rheumatoid arthritis, acute pain, and as an analgesic and an antibiotic as well. It is also used as a chemoprevention agent and to reduce the number of colorectal polyps. It is a selective non-competitive inhibitor of COX-2 enzyme, which is involved in inflammatory pathways. The diagram here shows COX-1 and COX-2 binding sites and shows how Celecoxib chemical structure and how Celecoxib has a bulky site grouping which is easily accommodated by the little side pocket that the COX-2 binding site has, so it has a greater inhibitory effect towards COX-2 rather than COX-1. While COX-1 is a more housekeeping enzyme, COX-2 is expressed in inflammatory cells, and Celecoxib acts by inhibiting this enzyme. Side effects and toxicity of the drug. Side effects mainly include GI effects, but the most important side effect of Celecoxib that has been observed in many clinical trials is cardiovascular events. This slide shows the PALM-GKB diagram of how Celecoxib is extensively metabolized in the liver, and how the CYP2C9 gene it catalyzes the reaction where Celecoxib is metabolized to hydroxycelecoxib through methyl hydroxylation. It's been found that Celecoxib also binds to some of CYP2D6 substrates, but those that have a narrow therapeutic index. More about the CYP2C9 gene. It metabolizes over 100 drugs. It makes up 1/3 of the total CYP protein content in the liver. So if a subject were to take more than one drug and that is metabolized in the liver, excreted by the liver, then definitely drug-drug interactions and genetic variations in CYP2C9 will play a part in dose response, drug response, and those concentrations that are bioavailable. The caution that has been raised for CYP2C9 for metabolizers is for clinicians to start treatment at half the lowest recommended dose and consider using alternative treatment in patients with certain conditions like juvenile rheumatoid arthritis, who are known to be poor metabolizers. There have been several publications about the CYP2C9 genetic variations in CYP2C9 and modeling publications, but the one that I found interesting was published in 2013. It's called Quantitative Prediction of the Impact of Drug Interactions and Genetic Polymorphisms on CYP2C9 substrate exposure. It attempts to create a drug-drug interaction model to predict impact of DDIs on drug exposure, and proposes dose adjustments so that whether you're a poor metabolizer or an extensive metabolizer, you have equal values of drug exposure. And two main coding variants have been found of functional consequences, with allele frequencies of around 11% and 7% in Caucasian subjects. Potential clinical utility. There might be significant potential, if not for the drug itself, but the mechanism of action. In my opinion, with recent research indicating an inflammatory component to cancer, the COX-2 pathway may be important for chemoprevention. Also, with novel drug delivery methods, selective COX-2 inhibitors like Celecoxib may be in future administered to be more selective as opposed to a systemic drug, which means fewer toxicities and side effects. In conclusion, I feel that more pharmacogenetic studies are needed, and creation of models like the paper that I just talked about there, would contribute to the development of specific dosing recommendations based on CYP2C9 genotype or drug associations. These are my references. Thank you for watching.